Get started. I'm Shirley Kessel. I'm the executive director of Miles for Migraine, and I also live with chronic migraine. I just want to say that this is a very complicated topic, and living with migraine is a whole body disease, and it's not something that we can control. It's not something that's our fault. And when you have to throw in getting medications from your provider, and then you have to worry about uh, getting a prior authorization, which means your insurance company rejects your prescription and then you don't know what to do. This is a full-time job. So that's why we're here this evening. I see that the chat is disabled, so that means you should have an opportunity to put questions into the Q&A. If you see the Q&A on your screen, you could do it there. Uh, I also want to say that a little bit about Miles for Migraine. We are a national organization that supports people living with migraine throughout your journey. And we do this by offering events like this, education, whether it's about living with migraine, how to live your best life, knowing about what all the medication options are, and understanding that taking medication is only one part of the toolkit because migraine is a very complicated disease to live with, and you need more than just medication to help you if you're somebody, especially if you're a chronic, someone living with chronic migraine. And knowing that chronic migraine typically comes with a whole host of other comorbidities. And so, again, none of these are your fault. It's just that the migraine brain is wired differently than someone that doesn't have migraine. So understanding it's good to be part of a community and come to whether it's Miles for Migraine or it's one of our fellow other nonprofits in our community, we all try to work together and offer programming that you can have a whole slew of choices in the headache and migraine community to hope that you will have your best life and live your journey in a way that allows you to do the things you want to do. And if you can't do those things, it's not your fault because, again, this is a very hard disease to live with. We also have races around the country to bring more awareness that migraine is worth having a public event to show people that, hey, this is serious. And it's just like all the other disease states that you see out there in the world. Migraine is just as serious. We also have support groups where you can join virtually. We have them almost every night of the week. And we offer an advocacy training program. We actually offer this information in our advocacy training program in addition to learning everything you need to know about how to advocate for yourself with friends, families, coworkers, and we give our proceeds to the fellows that also participate in those programs. Doctors in training receive funding from Miles for Migraine for the 34 fellowship programs we work with around the country because we have a shortage of clinicians, which I'm sure you're very aware of that if you're living with migraine or another headache disorder. And we have family programming, and I'm going to stop there and I'm going to share my screen now and get this conference started. I just want to take a moment to thank our sponsor. This program has being supplied by a sponsorship from Pfizer, so thank you to them. I first want to introduce you to Carla Allizzo, who I don't have her bio up in front of me, but I will tell you that she is a long-term employee of Jefferson Headache Center in Philadelphia, and Carla knows everything there is to know about headache and migraine, including about prior authorizations. So, Carla, please get us started.
Okay. Thank you. I am pleased to be here this afternoon because consider myself expert in prior authorization. So I am the nurse supervisor at the Jefferson Headache Center. Dr. Steven Silberstein, we used to have the floor in Jefferson in 2008, and he had asked me to move over to the ambulatory outpatient practices shortly thereafter. So, of course, I said yes, and I've been there ever since. So, I was happy to do this for my migraine patients. We do prior auths all day, every day. I have a team of nurses that help me, but I have to just dive in and do them every now and again, especially when there's a challenging one. We all put our heads together and figure out how can we get our point across that this patient needs this medication. What are we missing? So, next slide. What is a prior authorization? It's a review process some insurance plans require before they will approve certain medications. It ensures the treatment meets insurance rules and medical guidelines. Similar to security screening at an airport, everyone must follow the same steps, but some items get extra checks. Prior auths vary through insurance, employers, and plans, and also states. So if you have the same plan as someone sitting next to you, there are different carve outs underneath them. You never really know what it looks like, what you're going to need to have tried and failed until we actually dive in. Next slide. Why is the line so slow? Just like TSA, medication approvals involve many steps. High patient volumes, it's similar to the long line when you first get into the airport and you're like, oh no, I'm never going to make my flight. Our clinical process is hundreds of these requests weekly. I always say the apps now, the pharmacy apps will alert the patients that the medication requires prior authorization before they've even ever checked out of the office. So from the patient's point of view, it is a long wait because they found out the moment that they got the drug ordered, but so did everyone in the waiting room that day because all of our migraine medications need prior authorizations. Each insurance is like a different airline. Each has its own forms, rules, and like baggage policies. Most do use Cover My Meds, which is a centralized hub, which is we're very grateful for Cover My Meds. I think it is helpful, useful. It's a big dashboard. We could log on at any time and see where we are in the process. Many plans use alternate hubs or websites. Some medications require full screening, extra documentation, multiple signatures, or clinical notes. Delays are common. Insurance may request more information or perform multiple reviews. Some insurance plans still require that we don't use anything electronic and do everything via fax. That would be the longest delay, where we have to call the plan, request the form via fax, receive the form through all of our 300 faxes that day, and then we have to pull it, fill it out, and then fax it back. Next slide. So new migraine medications since 2016 require a prior authorization. Migraine patients require prior authorization for every medication in their toolkit. The new ones, many of these drugs are $70 a pill, so you're not just going to be able to go and pick up the prescription. You know, when we are sick and we're not feeling well, and we go to the doctor and he prescribes an antibiotic, it's rarely blocked at the pharmacy when we go pick up the antibiotic. We're on our way, we feel terrible, we just want to pick up that antibiotic, we're able to pick it up. Migraine medications, everything is blocked. Every single medication in your toolkit is blocked by insurance. Next slide. Including and not limited to the older generation medications. So once we've gotten the newer ones, and then some of the oldies but goodies, the triptans, some of them are still effective. The plans now limit those to 4 pills per month or 4 injections per month. So now we have to go for a quantity limit override. which is a whole nother set of barriers that we have to go through in the insurance. And it's not as easy as a prior authorization because it is approved, but now we have to say, please give us more. And these frequently need monthly overrides if a patient needs to have more than one triptan. Next slide. Even nonsteroidals that are specific to help migraine patients. The first line, like the naproxens or anything over the counter, you can simply walk in and get it over the counter. But the ones that work really well and fast also require a prior authorization. And these are step therapies. You have to make sure that you've tried all the ones that they prefer you to have tried before you could even go on to anything else. And you could go to the next slide. Why it takes time. Each PA involves reviewing chart notes, verifying diagnosis and treatment history, completing insurer-specific forms, uploading clinical documentation, responding to the follow-up questions, tracking approval, denials, and appeals, communicating with pharmacists and specialty hubs. I just want to focus on the diagnosis and treatment history. Sometimes we could even be at a difficult way to go from the diagnosis. Some plans will only cover it for a specific migraine diagnosis, not all migraine diagnosis. We always want to have the clinical documentation. And then in the event that they would ask us a follow-up question, we have to hunt that down in a very high volume practice. So whereas the patient may know, the patient will, because they're waiting for this medication. They're sitting there waiting for this medication. They were informed, maybe it was a text or an email. We're still waiting to hear from your provider. So we've already answered 17 questions. Probably only 6 of them were relevant to the actual medication. But yet there's this looming one that we have to find. Did they fax us? Did they send it? Did they, call us and specifically ask through a representative? We're now on the hunt for this one specific question that they could have asked us from the beginning when we originally submitted the prior authorization. So then that becomes a real time sink. And then tracking appeals and denials. And once we get the confirmation that we've gotten the prior authorization, then we have to also call the patient. Sometimes we have to call the patient, let them know. And sometimes they're getting blocked at the pharmacy too, because maybe the pharmacy is not putting it in for the amount of days per month. We could have gotten this amount per day, and your plan only says only put it in for 21 days, 28 days, 30 days, a month. I don't know. And I'm not sure. I can't speak to all diagnoses, but the month has a different definition throughout our migraine meds. Sometimes it's 28 days, sometimes it's 21, sometimes it's 30. So it really is a guessing game. It's trial and error. You have to call and recall and call again so that you could find these little clues to figure out the next step to get the authorization to go through for the patient. You could go to the next slide. How patients can help speed approvals. Keep your insurance information up to date. Plans change frequently. This is especially difficult when your employer change. Sometimes your employers could change your plans twice throughout the year. It happened to me recently. So you always have to get your updated insurance information to your healthcare provider, in addition to the pharmacy benefit manager information. We no longer just could go with, this is my insurance coverage. We need specific criteria to get these things approved. Attend regular follow-up visits. Super important. Plans may deny medications if they determine that the last office visit we attach to it is not recent enough for them. It's not, we don't know this until they deny it, but they could deny it. and then respond quickly if we call for information. Sometimes we're unable to locate if you tried one specific medication that's required. So we're definitely going to want you to call us back. And if you can't figure it out, sometimes you would have to, because you could have had a new plan since you tried that original med that they're asking for. So we would sometimes have to let you, all right, just call CVS to see if you let's talk about this is what the medication is called. Let's try to figure out if you've tried it before. Fill out pharmacy benefit questionnaires. So this one challenges me because sometimes we have to have the patient complete a form to say that we could, go continue to fight and appeal their denial when we didn't have to complete the form when we first started the process. But then, we have to have a patient that has a migraine and feels awful, get a form, sign it, and scan it back to the plan. That one really irks me. And then we could go to the next slide. All right. So now understanding the medication appeals process. So let's say we've done everything right. We've given them all their information and it still comes back denied. Now we go into appeal. This is when the gloves come off, because at times the denial reason is not even a question that they asked us. They could deny it for a reason that wasn't even asked. And then we could say, oh, you didn't ask it, but here's the answer with clinical documentation to support that this patient is eligible for the medication. Still not good enough. Then we have to go into an appeal. Insurances may deny a medication. They require more documentation. They want proof you've tried other treatments. The medication is not on their preferred formulary, or they request it and meet their policy requirements. So the appeals process is the exact same that we've already been through. It's framed slightly differently. It's in a letter form. We will add resources at the bottom just to say, or references to say why we want this medication, but it's all the same information. It's completely redundant. We've done, starting with, we put the denial number on the head of the appeal letter. So then we have to give them all the information again and then send it off. But appeals now take 7 to 30 days. They're not as quick. Usually a prior authorization could be determined in 1 to 5 business days, but the appeal process takes longer, I guess, on administrative end of the plans. Next slide. So we always renew the denial letter. We determine why the request was denied. Insurers must state the reason why. So this is like a matching game. We're really just matching bullet point by bullet point. Didn't do it, did do it, and we just follow the directions. Don't leave any out. Don't omit one. Don't skip one syllable, because they'll continue to deny it. So we get the visit notes, the treatment, the failed medications. Again, all this was provided all the way up until this point. And then we submit the appeal. And then the insurance takes a longer time, and then we see if we get the approval or denial. I often tell patients to keep track of their approval dates, calendar somewhere. Fill your medication, especially as that if it's an acute med, fill your medication up and until that point, so that you do have a little stash of your migraine medications, because everything in your toolkit is going to need a prior authorization. And just when we're in a good spot with your prior authorization, your formulary can change. They could decide in half the year that even though you have a prior authorization in place with dates, they will not honor it. So then they've switched what they're deciding to cover this time. So they're going to just let us do it all over again with a different medication. Next slide. And then provider for the appeals process. This is the most cumbersome barrier. The appeals process, and then if it has to go into a peer-to-peer, we can't always go to a peer-to-peer, we have to follow the appeals process first. Now we have to schedule a peer-to-peer. That means your prescriber has to speak to their medical director and say everything that was already stated along the way. But you want to have your provider have you have reviewed the denial letter, so he kind of like has his ducks in a row for when he speaks to the medical director. But now you have to schedule a peer-to-peer, most likely during clinic facing hours, or sometimes we have a moment where we could get it in at a lunch break, but the provider has to step away from patient facing hours in order to answer the medical director with all of the information that had already been provided. And then my role in supporting appeals is I complete and submit all required documentations. I coordinate the peer-to-peers despite insured delays and poor availability. They might not always have, the next day. They could have the following, another 3 days. It's not always convenient. And then I have to ensure that they have all the information. So I always make sure that it's letting the patient know all this is going on behind the scenes almost sounds as if we're completely don't feel like doing it. If you're the patient and they are calling, they're trying to advocate for themselves, but they are told your doctor only has to. And I always say your doctor has and will and continue to do it, but they always let the patient know that we haven't answered this question or that question. So it becomes extremely challenging to prove to our patients that we are fighting for each and every medication that the doctor has prescribed. So sometimes, most of the time, we'll win the peer-to-peer or the appeal, but at times we don't. So you have to then go to their formulary preferred. That's when you have to begin to really track and calendar your migraines for your next follow-up appointment. You're going to want to have at least a good 2-3 months while you're on the medication that they asked you to switch to, and let us know if it is not as good. Whatever that looks like to you, whether you have less social days, you have more days from missed work, when you can't actually go to the supermarket, or you're just in bed. So whatever quantifying factor that is, we'll put it into the jargon that they want to hear. We'll turn it into whatever percentages that they want, so that we could reapply for the preferred. And then sometimes we'll win that appeal that way. Next slide. And that's it. Anybody have any questions?
Okay, we got one question from Carol, and I think that this is important for providers and patients. Can you talk to a little bit about why it's important for patients to bring an entire list of every medication they've ever tried and that has failed them? And why clinicians are constantly asking them to do that. Talk a little bit about step therapy and why, and maybe you can share what you do at Jefferson. Yeah, I know you've got a new worksheet, I think, that you might be working with.
Yeah,
Okay.
yeah. So our patients probably feel that they're in an interrogation room by the time they're done with the nurse for their intake, because we do not take no for an answer. If it's like, we'll be sounding it out. We'll go back to like Ronald McDonald. We'll just be like, does it start with a T? Does it start with an A? Do you think it, did it make you cough? Like, we'll do whatever we can to figure out. Your plans want to know if you tried all of the medication that they deemed would be covered before they would grant you access to the medication that the provider is giving you. So it's important, and it's too difficult for the doctors have a rule of thumb. We have a general map of what should be tried and failed. We have big categories where don't even think about ordering it if they didn't try A, B, and C, which would be the step therapy. But then there is, once you do the deep dive, you find out, well, they wanted you to try these together at the same time. And then you didn't show us that you did this together at the same time. So then we go back to the drawing board and we pull files, and maybe we get some dates that we could speak to that the patient has tried and failed. Ultimately, you want to highlight the fact that there could be a contraindication why you haven't tried that. Not every patient can try every medication safely. There's never, rarely, there's a spot to put a contraindication. So getting that information to the pharmacy benefit manager is extremely difficult because there's no good place to put it, so they wouldn't read anything extra anyway. So that's a call. So don't even try to figure that one out via electronic transmission.
Okay, thank you, Carla. Okay,
Thank
we're
you.
gonna we're gonna move on to Lindsay Videnieks' presentation, and I see some new questions in the chat, and I'm gonna say hold on because I think your questions are gonna get answered in the next presentation.
Yes.
So, Lindsay, please take it away.
Okay, thank you so much. And before we get to me, I want to just acknowledge how lucky Carla's patients are to have her. I'll give everyone homework on this call, which is say thank you the next time you are in your provider's office because it's an immense amount of hours and paperwork and support. And we're going to talk a little bit about the importance of that, especially for migraine patients, the clinician-patient relationship. And so a lot of that has to do with what Carla's been talking about. So before I move forward, with that, I just want to introduce myself, Lindsay Videnieks, and we can go to the next slide if you want to do a little who we are, what we do. So I am with Mortar Strategies, which is a public affairs and government affairs firm in Washington, D.C. But for the last decade, closing out in December, I was the executive director of a policy-minded nonprofit called the Headache and Migraine Policy Forum, and so have worked closely with Shirley for all that time. We have been shoulder to shoulder on a lot of these challenges, the ones that Carla's talking about, what we guess we would call utilization management barrier fights, if you will. So a quick note about my firm. So, Mortar Strategies really is focused as we are today on policy issues. We also provide public affairs support, and then my background is former Capitol Hill staffer. I have a specialty in background appropriations, and I also have done some campaign work. So, bringing that mindset to understanding how we might advocate for patients and clinicians and trying to help policymakers kind of understand the bigger picture. Carla talked a lot about the day-to-day sort of blocking and tackling, that very tactical, how do we help this patient and the next patient? We also, on a policy level, think about it in terms of the whole. So if there's a systemic, change, reform, benefit, we can help move forward. Groups like Miles for Migraine and other groups in the nonprofit space really tried to do a lot of that work. So kudos to Shirley and to Miles. Before we get started on the next slide, something Shirley says a lot, and I think also Jamie Sanders, who's another advocate, which is, you all are here to make advocacy part of the prescription. So there is the care and treatment that occurs in the doctor's office and with clinical providers. But in terms of how much we are asking of migraine patients to advocate for themselves, it's a lot sometimes, and it can feel that way. But we intend for this program to feel empowering so that you feel like you have some tools, so that you know you have people on your side. So, with that, we'll keep going to the next slide. First, I just wanted to acknowledge what I think we all know, which is what Carla was talking about and how challenging prior auth is. And I want a special, sort of call out for migraine patients. And I say this a lot, which is, all disease states present their own challenges, but for migraine patients, and I'm speaking to the choir here, you don't know if you have 3 hours in a day to spend on the phone, right? Like that could be your best day of the week. And is that how you want to utilize that time? So whenever we make the case to health insurance companies and we do direct outreach to insurers, insurance commissioners in a state, we try to help educate them about, yes, perhaps a patient living with high cholesterol is going to take time out of their day to advocate for a prior authorization issue, but for a migraine patient, it's even higher burden because you just don't know when you have that much time to spare. So I would just say there's been very updated as of February national polling on this issue. I would say all of this is probably exacerbated in the migraine community. Let's go to the next slide. But I will say, and this is not the rah-rah slide, but we have made actual gains and successes on individual, as Carla's talked about, appeals and getting access for patients, but then also on a policy level, we have changed national policy because of groups like Miles and other groups that are doing that work. So the fact that you're on this webinar today and trying to learn how to sort of, find those tools and use them, there are success stories, and we'll talk a little bit about that. Let's keep going. But first, I want to say that, and this is, when we, the migrant community, go to health insurance companies, I think there was a question in the chat about this, which is like, okay, how do we help the actual insurers understand that, this is not only costly and burdensome to patients, but there's a cost to the entire system, right? Health insurance companies are for-profit enterprises. They are there to provide value to their shareholders. What we have tried to help them understand, besides the sort of scientific and quality of life concerns, is that when you are not providing access to treatment, either through excessive prior authorization or step therapy, there's a cost to the system because migraine patients are frequent flyers of the ER. So if you're not going to pay for it on, say, the pharmacy side, on the medical benefit side, an under-treated migraine patient is going to be a high user of healthcare resources and very expensive healthcare resources. So when we are talking to policymakers, this is one of the arguments that we use because we know the financial sort of bottom line argument is important to them. This is new data that was just published in January. Full disclosure, I was a co-author on this journal article, but this is the type of peer-reviewed research that when you are doing sort of that interaction with the health insurance company, not you, but the groups, this is besides medical guidelines and electronic health records. When they're looking at decisions, they actually will look at peer-reviewed literature like this to help make change. So related, and this is where, if we can go back one, sorry, Shirley. Let's go back. Yep, nope, next one. That's okay, one more. There we go. Okay, so I do want to say, like, this has been somewhat doom and gloom, but we have good news. So in 2024, the American Headache Society updated their guidance, basically shared a position statement saying that CGRP should be first line preventive treatment. So what that meant was rather than having to step through a bunch of different older treatments and forcing patients to, wait months to get access to what their provider is prescribing, is basically saying, hey, as a medical society, we're saying that CGRP treatments, some of those newer innovative treatments, should be the first thing you get access to. And so, again, health insurance companies, this is where the policy community comes into play. A number of the groups, including Miles and others, sent letters to the 10 largest plans in the country. And within 2 or 3 weeks, they all decided to start following this medical guidance, this updated medical guidance. So there are still access challenges, but some of the largest, like Cigna, Aetna, United, they all agreed, at least in writing, to follow this new protocol. So that basically means that hopefully removing some steps for patients. And that's great news for preventive care. So let's go to the next slide. This really is what Carla was talking about, but I wanted to share this as a patient-friendly resource. This is really for patients, and I'll pop a link to this in the chat. So my former organization published this sort of, and it's on the website, but published a really friendly, patient-friendly guide. Can I put this in the Q&A? I'll just put it in the chat. Is that fair? Can I do that? Let's
I
see.
think the chat is disabled.
Okay.
You might have to put in the Q&A, but I just want to let everybody know that we are sending out this presentation
Yeah.
afterwards, and it will have links in there.
Okay, yeah.
Yeah.
So if you do go to Headache and Migraine Policy Forums page, there's an advocacy tab and it says file an insurance complaint. So all across the country, there are 50 different health insurance commissioners, right? So they view healthcare and health insurance as a consumer affairs issue. You, as a person or a policyholder, you are paying for a benefit. You are paying for a service from a health insurance company. So each state has a regulator in that state. That is the health insurance commissioner. It's actually the commissioner of insurance, and they can do everything from, fire insurance, hazard insurance, but it includes health insurance. And so their job is to basically be the watchdog or overseer in their state for the states, for the plans that are active in their state. So that could be Blue Cross Blue Shield in Mississippi, it could be in California. And every state has a link to, and we can go to the next slide, in terms of filing an insurance complaint. So if there is an access burden, and this could be, if you talk to your provider's office and you say, okay, I'm having this issue, I'm having this challenge, either a patient or a clinician can go and click on one of these links to your state. See on the upper left quadrant here, My Patient Rights. And you can, if you, well, again, we'll share links to this. You can click through and file an insurance complaint. And what it does is it almost presents an alert to your health insurance commissioner saying, I'm not receiving access to care and treatment. Either I'm being denied because of, my insurer saying they don't allow combination therapy, or I was one of the most perhaps egregious examples I could give was I believe there was a patient in Kansas that said they were denied access to treatment because it was not administered by a UCNS certified clinician, of which there were zero in the state at the time. So it's ideally you file an insurance complaint if you believe that you're not getting redress from what Carla talked about. You want to start where Carla talked about through the normal appeals process, the sort of peer-to-peer where the doctor's office is working with the insurance company. But if it becomes a time where that, appeal is not successful and this seems to be a larger issue, either the patient or the doctor can file one of these insurance complaints. And what that does is it triggers the health insurance company or health insurance commissioner to send a note to the health insurance plan and say basically what's going on. And 99% of the time, that will result in a reversal in your favor. So, this is a not commonly known tool. On this screen, you can see in the upper left is a map, and if you toggle over your state, it will send you to the Division of Consumer Affairs for your state, so you can fill it out online. On the right is an example on their website. They will, if you click on the state, what happens. So if you clicked on California, it will kind of walk you through the steps and how to do it. On the bottom left quadrant is NIAC. So that's the National Association of Insurance Commissioners. And so they basically are like, if you can think of it, almost like a trade association for all the different health insurance commissioners around the country. And they gather and are sort of aware of these issues. And then the bottom right, I believe that's the state of Florida's website. So when you click through, it looks like something like this. So every state, of course, is a little different. I wish we had a uniform system, but we live in a 50-state country. So every website for each state will look a little different. Um, let's go to the next slide. So we talked about how, there's this almost if you think of it like a funnel, you're starting first with your provider's office. they are doing that hard work in terms of the paperwork and making sure every T is crossed and every I is dotted. And then you get to perhaps an appeals process. And then you get to maybe file an insurance complaint. Above here, and maybe this is thinking about patients at large, are these reform measures. And so, you heard Carla talk about, sometimes it's a very patchwork system where some plans say, okay, I have 7 days and I'll give you an answer. It can be up to 30 days for an appeal. There's no uniformity. This map is indicative of places where state legislatures, and this map I didn't create it. This is from the American Medical Association, so I can assure you it's good, and I don't, and this is above my pay grade. So this is a great map, and again, you'll have the link. You can click on your own state and see what's happened. But that means the purple states are places where there's been some law passed to either reform prior authorization, to basically say, okay, you have 24 hours, insurance company, to give an answer, or it could be about speed and timing. And so the blue states, it's where I think legislation has been introduced or hasn't moved forward. But you can see where we're kind of at a 50-50, where some states have made improvements and some haven't. So that's good news, but that's kind of what Congress or the administration looks at as they're seeing whether there's an issue that's almost ripe enough to take federal action. So, if Congress were to pass a prior authorization reform bill, that would apply to all the states, right, under federalism. Right now, we don't have one. There isn't a federal prior authorization bill that's passed. So right now we're in this patchwork situation. But I have good news if we'll keep going. Next slide. Yeah. So earlier this summer, the administration under President Trump and the Center for Medicaid and Medicare Services, CMS, went to the insurance lobby. That insurance lobby is called AHIP. So it's called America's Health Insurance Plans. And think of it like a trade association. They basically are like NIAC has its organized, 50 health insurance commissioners come together to talk about issues. The industry of health insurance comes together. That's United, Cigna, Aetna, all the big players, Blue Cross Blue Shield. And they have a trade association, a very powerful one called AHIP. Now, in this current political environment, I think the administration probably thought the likelihood of getting a national or federal prior authorization bill was pretty low. So what the administration did was it went straight to AHIP as the basically say, go regulate yourself, right? Like you need to come up with some things to make some change here, or else we will do it for you. And so smartly, AHIP came out with their sort of pledged commitments and how they were going to try to address this issue. The short answer is, and some of these bullets are, more technical ways, but of describing, but like they're investing $1 billion into AI for streamlining prior authorization. But the pledge commitment, and this is the big headline, remember what Carla said about how often prior authorizations take a little longer than happening in the office. They are saying by 2027, 80% of all PAs will be adjudicated right there in the doctor's office, like right there. So that's good in terms of time saving. Of course, we want to make sure that AI is used in a way that is pro-patient. Another sort of notable bullet is when you see continuity of care when patients change health plans. They have pledged and committed to if you change your employer and you change health plans because of it, your PA will be good for 90 days. So that will carry over. That's new. Again, this has not happened yet. This is something they've stated that they want to do. It says by January 1st, 2026, but I don't think that's in place yet. So they're trying to make positive changes on their own, not waiting for Congress, not waiting for CMS to do it, but with a strong suggestion that they ought to do these things for themselves. So we can go to the next slide. The great news is the migraine community has been engaged on this issue. So the Alliance for Headache Disorders, Advocacy, and some others have been developing this pilot. So AHIP obviously cares about their members, but this is for all disease states, right? This isn't just for migraine. It's for cardiovascular, it's for neurological, it's for obesity care, it's for a lot of different diseases. The migraine community has offered to be a pilot demonstration program for AHIP to say, okay, if we can figure out how to do this right, it could be a model for other disease states. So what we're asking for is, can we get all the plans to follow uniform guidance? Like some of them do, some of them don't. Let's just get some uniformity. So this is very much in the beginning stages. I think this year it's going to move through that process, but that's very good news in terms of some of the, backlog and the time-consuming waits that Carla's talking about. If AHIP can get its act together and sort of self-regulate their members, I think that will go a long way in having some uniformity, so it's not so patchwork. Let's keep going. So I guess this is what in campaign terms, we would call a call to action. So for patients on the line and for providers, there's some things you can do, right? Aside from, the hard work that folks are doing to just adjudicate individual claims, there's bigger picture things you can do. So Miles for Migraine and other groups are developing educational materials on utilization management issues. You can share those. Everyone on this webinar is now a little more educated on the topic. Find somebody else to talk to about it. This is kind of an arcane topic, but at the same time, everyone knows someone who's dealt with a health insurance issue. So second, file a consumer complaint. That's a tool you have. You can do it. Whether you're a patient or a provider, sometimes both. If you are able to file that complaint, the health insurance commissioner, it's almost like a stack on their table of how many issues they see in a particular area. We want them to hear from migraine patients to understand that these are systemic challenges. Create a testimonial. So I know many of the groups, including Miles, they will videotape patients. Patients can tape themselves and share their story because honestly, the lived experience goes a long way in helping people understand the real burden of all of these issues. And then direct advocacy. So a lot of the groups send letters, individual letters to plans. You can testify. I know, Shirley, you've done Headache on the Hill. There are all these opportunities to sort of do lobbying or not lobbying. A lot of things fall under the bucket of direct advocacy. So they just need to hear your story and they need to hear it either in person or through virtual meetings. And then finally, earned media and radio media tours. So, those are sort of environment shaping opportunities, but, migraine is an invisible disease, but doesn't have to be a silent disease. So if you can talk about your disease, that gets other people talking about. And sometimes that, if you're comfortable, if that's in a public space, there are folks here to help support you if you'd like to write an op-ed or some other sort of public statement. So I think that's always beneficial. I think I might have one more slide. This is a final slide that has some additional resources, but Shirley mentioned we are going to share this deck out. So a lot of these hyperlinks you'll be able to click right through and look at some of the resources. And in the notes section of a couple of the slides I shared, there will be hyperlinks to those resources, whether it's filing an insurance complaint or, your appeal process. So I think that might conclude everything I have to share.
Yes, great. Excellent work from both of you. And I actually learned something. I'm so happy. And I'm sure everybody has a lot of questions. So what we're going to do now is I'm going to turn it over to Lindsay and Carla to take a look at the questions just for a minute and take turns answering them. If we've already discussed them in your presentation, obviously we'll pass on those questions. And I just want to mention that the migraine community is a very cohesive community and that the patient advocacy organizations belong to a coalition called CHAMP, the Coalition for Headache and Migraine Patients. And this is really important for all of you because when we come together and do all the things that Lindsay just talked about, this is how change is going to happen. And in pretty soon, you're going to be hearing from Miles for Migraine and also other organizations that are going to be asking you to write letters, asking you to record yourself, explaining what the experience was like when you got the denial or when you did an appeal and it didn't work, writing to your state legislator or contacting your state legislators is also a really important part. Make advocacy part of the treatment plan. It doesn't have to be, something that's a really high lift. It can be something simple like writing to your insurance commissioner and inquiring about a denial. That's advocacy. Talking to other people, that's advocacy. Talking to your provider, asking questions, what can I do on my end? That's advocacy. And bringing that list of medications that have tried so many times, or I've tried and they didn't work for you, that's really important. So I'm going to pause there. Hopefully, Lindsay and Carla, you've had a chance. I'll turn it over to Lindsay first. Did you
Yeah.
see a question there that you can
Yeah,
answer?
I think let's just go in order here. Carol's question was, is there any option for medication approval when migraine neurologist has completed PA and the insurance denies, stating you have to fail every drug on their list first? We talked a little bit about that. I don't know, Carl, if you want to add anything, but the first step is what Carla will do in the office, but then I would just circle back on that insurance complaint. So it seems like if you are not making it through the appeals process, then yes, you should take that next step and try to do the insurance complaint, Carol. Um, the next question is a combination therapy question. So I don't know, Carol or Carla, if you want to address this one, but it says, what are you hearing about people who require multiple migraine medications like Botox, Vyepti, and Gepants? Specifically, are insurance carriers bumping people off of medications that were previously authorized because the insurer did not show gains? Do you want to take that
Great
one?
question. That's the part where showing up for your follow-up visit is imperative. Sometimes you will get denied because you're not doing as bad as they want you to do. And then we have to circle back and say, because they are gaining benefit from therapies A, B, and C, this is the reason why they aren't doing as terrible as they were when we first started. Some plans, federal, will kick off a CGRP when another CGRP is approved, even if it's one's acute and one is prevention. So it will kick it out. It won't tell you they kick it out until the next time you go try to pick up your medication because you thought that it was approved.
That's a great answer. And Georgia Ann had a question about what happens to my Neurotech authorization when I switch neurologists. I think under the AHIP, I'll let Carly can jump in, but I think under what AHIP is trying to do is grandfather in that PA for 90 days. That may not be the case right now, but that's where they're trying to get to. So,
Great question. Most of the time, it's attached to your plan, not to the provider. So if you get your tech approved until April 2026 under Dr. A and you transfer to Dr. B, that follows you. You're probably going to have another refill on Dr. A instead of, Dr. B. But that's another thing. If you are switching providers, you have to have a little heart to heart of who's going to continue and maintain my medications in the next 6 months. Sometimes providers will just want to hand you off to the new provider, but you need to know when your Nortec's going to expire, because then the clock is ticking for us to resubmit it. And we don't know you as well because your previous neurologist might have been with you for a few years. We're just getting to know you. So we have to, kind of do a fast track and get that approved.
yeah. Jay Reed asked, is there anything going on to support migraine patients? The fights against the insurance companies, we kind of talked a little bit about that. But they did say, I assume their people reviewing are not migraine specialists. Bingo. We didn't talk about that. It's peer to peer, but it's not really peer. I will tell you, I, this is, there's one doctor I talked to in a different space who basically asked for the peer to peer's medical license because he said, if you're practicing medicine with me, you're part of the care team. And if I have to have liability insurance, so do you. Like but it's typically not a headache specialist that they're talking to. It is perhaps sometimes a podiatrist, literally someone who may not know very much about the disease state at all. I don't know, Carla, if you want to add anything.
Correct. That's why I have my providers armed with the denial information so that they could obliterate them during the call.
But you'll do it with a smile.
Yeah, once we get to that stage, the gloves are off. So
Oh yeah, yeah. Okay, Lindsay S. If a PA goes through and the drug isn't on our formulary, would we still have to pay the cost of our insurance? For example, Qulipta. My insurance deems it's not on the formulary, but they approved it for the days, then the PA went through. They're going to treat it like a tier drug, though. Also, why are patients on Medicare still not allowed to use copay cards? Do you want to take that one, Carla?
I don't know the answer, but I steer my Medicare patients to the drug manufacturer patient assistance programs to see if they qualify when that is an option. And then there is the Medicare prescription savings program that a lot of my patients I let them know about, but I think it's cumbersome to get started and chip
Yeah,
away at and
yeah.
it,
Betty has a question. Love that CGRPs are first line. However, most are in tier three, so that's cost prohibitive, at least for Medicare patients. Any advice there?
no, the only advice I have is they're going to tell you the first line representative is going to tell you that they could lower your provider could go for a lowering cost. You can't with branded medications. I've been back and forth numerous times to where I had to figure out like at least 5-6 times like it absolutely can't. So you wouldn't be able to lower the cost. So you may have to try an alternative, or it depends where you are in your deductible for that year. Then the out of pocket expense goes down a little bit lower. Sometimes if you meet your deductible on other things, then maybe you could start. Not the best idea, but these are the barriers that our patients that are suffering have to go through.
That's true. Sakshi had a question about it seems like a provider perspective, which is they've had denials for patients where the insurance requested provider availability options for the call. And to your point, Carla, like they're not really trying to make it an easy process. That's happened repeated 3 times for 2 different patients. I absolutely think that that would be, a situation where you could engage a health insurance commissioner through an insurance complaint. Because again, to your point, this is a systemic issue, right? You're having these challenges across several patients, and it seems to be a problem with the insurance company. I don't know, Carla, if you'd add anything.
I echo what you have to say there. That would be definitely an escalation, but it's not uncommon that we experience the missing of the calls when we are scheduling them.
Oh yeah, that's not by accident. You know,
Purpose.
right. Okay, I know we're at time, but I want to get through one or two more. Someone had a really important question about if I file an insurance complaint with the state, am I in danger of retribution from the insurance company? You should not be. That you are protected under, it's not like a whistleblower type of act, but when you are filing an official complaint with the health insurance commissioner, that should not come into play whatsoever. I can't imagine if you were to experience any perceived retribution. I'm not saying, I can't say what your next step might be there, but I don't think that's an issue. We've not heard that. And then a bunch of thank yous, which I think we appreciate. Thank you so much. And then finally, to Jorge Sadohi, any headway on getting oxygen therapy for cluster headache or Medicaid, Medicare patients? I can't answer that, but maybe Carla can.
I can. We had headway and then we lost it again because CMS removed it from the guidelines, and then some oxygen suppliers are pulling out too. So Dr. Young is ferociously fighting with the oxygen suppliers for oxygen for our headache patients.
I,
Medicare.
be- I believe that. And
Yeah, and there's a cluster center at Jefferson now, which is
Uh-huh.
amazing.
Mm-hmm.
Well, I want to thank both of you for being here. You are both excellent presenters, and I have put the link in the chat. If everyone can please just take a moment to click on that link and fill out our post survey so we know what you are looking for in future events, how this event went for you. Again, we will send everything out in an email. If you registered, just sit tight, give us a couple days. You will get the slides, you'll get the links, and we wish you all the best and come out and visit us here more at Miles for Migraine. Have a good evening, everyone.